today we're going to talk about some endovascular repair. And the one thing that's unique about this place, and it's so nice to see so many friends from WashU here and Dr. Roselle, Dr. Johnson, it really is a multidisciplinary approach to this disease process. Here are my disclosures. So again, in 1984, Dr. Dake performed the first TVAR for the treatment of aneurysms. And at first, the impressions with TVAR were, it's a straight artery, it should be pretty straightforward. It'll be easy, right? It's a big tube, less complications. Can use AAA devices with some just simple changes. Facts. Thoracic aorta is large arteries equal larger stents. Diameter changes size systole and distally much more dynamically than in the abdominal aorta. There's increased migration forces on the device, especially in the arch as we make that turn. Deployment issues with a lot of movement. We're trying to become more accurate, and as we become more accurate, we're playing with head vessels and not as forgiving end organs as the intestines and the kidneys. And we have large delivery diameter and poor trackability, creating potential disasters in the aortoiliac segment. Arch angulation, imaging, and stent comfortability is definitely an issue. Conventional surgery, though, involving the arch is highly morbid. It's got a high mortality, high stroke, and as we've seen, it's got a high just overall complication, as we've seen in the previous talks. As we have more inexperienced centers, potentially, and as we expend our circulatory arrest times, our complications become even higher. And in the emergency procedures, and as we combine descending aortic involvements, once again, we have poorer outcomes. We can do better. Why is endo a challenge? Well, when we involve the subclavian artery, the distance between the subclavian artery and the left common carotid artery, the arch starts becoming angulated. The inferior aspect of the arch, the angulation increases, and now we start having a size discrepancy between the ascending and the arch as well as the descending. And then we can start dealing with aneurysms here, including the great vessels as well as the transverse arch. Pure endo arch stenting, it can't be done. That's what we said for the visceral segments, and we attacked those very nicely. But let's just talk about the arch a second. We have several zones, zone 0 to zone 4. When we talk about zone 3 and zone 4, we're talking about distal to the left subclavian artery. It's conquered with current devices. We have them for years. Zone 1 and zone 2 is we can debranch those easily, whether we do a left subclavian left common carotid subclavian bypass, that's transposition, or we can even further the zone with right common carotid to left common carotid and further do a debranching. These lead to an excellent result with potentially increasing our landing zone. When we look at early arch devices, particularly modifying some thoracic devices, we did this, and you can look at single branches, and a lot of this work was done right here in the Cleveland Clinic. We modified Zenith bifurcated devices, and we did an extra anatomic debranchings of the arch. Here you can see this with a single branch with corresponding extra anatomic bypasses. Commonly, we try to debranch the aorta, and we deal with this off the ascending aorta. And we think of this as a less morbid procedure, but like Dr. Johnson said, and previous people have said, that debranching is not always less morbid. We do it anatomically via stenotomy, come off the ascending, bring a dual branch to the innominate and the left common carotid, and potentially do a left common carotid bypass pre-op. We do an endovascular completion to complete this aneurysm as it involves the arch. And we have a hybrid approach to the arch aneurysm. Here's a further example of doing the same thing with having our completion elephant trunk. We all know that this has pretty much become standard of care in our place, where we can complete the elephant trunk and do a completion TVAR and bring it down to a nice landing zone. Again, as was mentioned before in the previous talks, if we have to, we'll bring it down and have to do a completion open hybrid approach to the thoracoabdominal aorta. There's some issues here. Side biting clamps aren't as easy as they say, right? There's calcification. You have consequences including embolic and retrograde dissection. Ascending aortic diameter, sometimes we can't fit a graft. You know, the biggest grafts we have is 46 to 48. Does not avoid arch tortuosity. Implants must still reside over a 270-degree arch. And again, there's a risk of embolic stroke just with the initial debranching. We need to do an open surgery, and we have to rely on the extra anatomic bypass patency. the other thing is, too, we do this big operation and we may gain a centimeter or two. We don't necessarily get all that much real estate. For endocalcium, it's not as much as an issue in the aortic arch. However, we have a big problem going towards the endo approach. It's much more three-dimensional than we think. We have to be able to develop an implant that can preserve the cerebral upper extremity and coronary blood supply, and develop a delivery system that we can do this accurately and able to handle those forces in the arch. But there's problems, like we said, unique to the arch. These forces, the 3D anatomy, and the imaging difficulty as well. You know, when we have 3D cross-sectional imaging, it's very easy to image, but anyone here that does any angiography of the arch, it gets much more difficult as we orient. But you know, sometimes it's not what the problem is you, it's what's next to you, right? So the other problem is the valve. How are we going to handle the valve? Handling that with having that next to us. So we do have some early experience here with branch device, and it's been shown, and this is presented at VEITH by, this is a 4-year result with the bolt and relay 2-branch device, comparing endo versus open, the branching. And there was no significant differences between the demographics. And the procedural results of the endo group were actually significantly much better than the branching. We are currently in a multi-center, non-blinded, non-randomized early feasibility study. We are one of the sites, as Dr. Moon is here as well, so it's nice to have a representative of the 2 of the sites. And just, ooh, can you back up that slide, please? That was my video. Let's try it again. Oh, I just got bikined. It did work out there. You never think it's going to happen to you, right? Anyway, well, that was a very nice representation of the...
No blood loss.
Oh, here we go. All right, look at that. So here's our preoperative CAT scan running at 10 times speed, so my New Jersey accent should be perfect for this. So right now we see so part of this whole relay branch device is you have to make sure you have good preoperative planning, good access, good arch, make sure you have minimal debris in that arch to help prevent any type of embolization and stroke. Here's a 3D reconstruction of the arch, and you can see that we have a limited aneurysm right there. We've been able to bring up the device. In this case is courtesy of Dr. Roselli and Dr. Perotti. The thing that makes this device track nicely is that you have the inner sheath advancement with active control. The device is deployed and has a large window for the branches of the innominate and the common carotid. Perform them the rapid pacing. And here's your main body deployment. The nice thing about this device, as your main body is deployed, you're still having antegrade perfusion to your head vessels. We validate our cannulation from the innominate. There's 2 branches, an anterior and a posterior. You try to put the innominate into the posterior. And this is the stent being deployed. And this is repeated for the common carotid. As you can tell from the one tough part is the angiographic visualization of all these markers. On 3D sectioning, it's much easier to see, but when you start doing the 2D angio suite, it's not as straightforward. Here's the completion angio. And then we have a post-op CT scan. Showing exclusion of the aneurysm. This patient went home in 3 days. There's a 3D reconstruction. We don't have to watch it again. All right, thank you for the ability to give this talk, and that is my talk on the endo approach to the arch.